This started.
Recording.
Mm-hmm.
Looks like people are starting to filter in.
Yes. Hello, everyone.
Good evening, afternoon. I don't know. Is this count as afternoon or evening?
It looks like evening, but I think it is still kind of afternoon.
What
It's
time
dark
does
out there.
What time does evening technically start?
about 5 o'clock in the
so it's still
winter.
afternoon.
Yeah, happy
It's
hour
like
is evening.
2:30.
Okay. Well,
That's
then-
right.
I had someone call me. They have PD and they asked not to call later than 9:30 or 10 because they go to sleep. And I'm laughing, thinking, oh, I'm in bed an hour before you.
I was gonna say that's kind of late.
I'm sleeping then too. Don't worry. We'll give it another minute or two for everybody
Okay.
to get in.
The last talk with the dog of the year.
Oh, that's right.
It is
David,
already
you
December.
started this with Dr. Leichliter. When did it start? What do you think?
A year ago,
it-
September.
I was gonna say David always keeps me straight. He tells me when we
Yes.
start. And good questions keep coming. So I guess we're doing a good job, and I guess people continue to have questions. So as long as people continue to have questions, we'll keep doing it.
Yeah.
All right. Well, people will probably keep trickling in. Casey, do you want to say anything first?
Just welcome. Anything, Christine or David? So glad you're here.
Nice to see everybody. Well, nice to read your names.
Yes, I know we're in the webinar format.
Yeah, I'm sorry. I'm multitasking. I've started dinner too, so I might have to jump up and check on the succotash.
Ooh,
Don't burn the dinner on my account. That's for sure.
yes. Okay,
All right,
well, take it away.
I will get started. Well, welcome back, everybody. I'm Dr. Leichliter, movement disorder specialist out of Allegheny General or Allegheny Health Network. If you're new to the game, welcome. If you've been to the game before, welcome back. Generally, the way this works is you guys send questions in and I answer them. I always like to start off with a few caveats, which are basically one, this is not a great forum for you to get individualized medical care, even if you're my patient. This is not a great place to say, hey, I'm on this, and this medicine. I'm having this problem. What do you think I should do next? That's a really good question you should bring up to your doctor, your neurologist, or your movement disorder specialist. The other caveat that I always throw out there is everything you hear is my opinion. I like to think that my opinion is based out of as much medical fact or evidence as I can come up with, but we don't always have that. And sometimes I am left making stuff up. Usually if I'm making stuff up, I'll throw up some quotation marks so you know that I'm making stuff up, or I will tell you I'm making this up. But everything that I tell you is my opinion. If you go to a different neurologist, if you go to a different movement disorder specialist, there is a possibility they may have a differing opinion. And so those are really the only things that you really have to be aware of. If you come up with a question, throw it in the question and answer section. If you were on last time, you remember I had some technical difficulties, and I still have some technical difficulties because for some reason I can't get my desktop computer to actually work from a camera standpoint. So I am back on my cell phone again. So technically still not quite figured it out, but we'll get there eventually. But I can look at the question and answer section on here. So if you come up with a question or if you have something, throw it up there, and we'll talk about it. I do have some questions that were emailed in ahead of time, and so I'll start with those. And if you guys come up with questions along the way, send them in. Let me know. That's what I'm here for. So some of the questions we start with. So there was a couple questions about apathy and depression. So could mood changes be a side effect of the Parkinson's disease medicines? Of course, the answer is yes. In case you haven't, if you've been on this call before, or this video before, the answer is almost always yes. Almost always, especially if you say, if could this happen, or if this happens, the answer is almost always yes. So the Parkinson's disease medicines can affect mood. Again, we're dealing in the dopamine pathway world or the dopamine world, and dopamine is directly involved with mood, much like serotonin is, much like norepinephrine are. All of these neurotransmitters or these brain chemicals can affect mood. Dopamine is active in the reward pathway. This is why some of the medicines that we have come with impulse control problems. And so the short answer is yes, the medicines that we use for Parkinson's disease can affect mood. And it can actually go either way. I've seen people get more depressed on the medicines. I've seen people get more, impulsive and agitated on the medicines. And so everybody responds to the medicines a little bit different. But the short answer is yes, mood changes can be a side effect of the medicine. And then it does sometimes come down to, although, again, it really only comes down to this as a last resort, do you have to put up with one over the other? Meaning, do you have to sacrifice mood to work on the movement or sacrifice movement to work on mood? And sometimes the answer is yes. This is a big thing that we come across in deep brain stimulator technology, but it also is true in medications. Unfortunately, all magic comes with a price. And in medication, sometimes it's the actual price, but usually it's side effects. And the same thing is true for every treatment that we have. And so you do have to kind of weigh out the risks and benefits, and that's something that you have to talk to your doctor about. And the key here is, again, communication. So, bring it up to your team, bring it up to your doctor, let them know what's going on, see if there's something that can be changed, or see if this is just something you have to deal with. Do some Parkinson's patients have trouble with brands of medications, meaning they can take one certain maker but not a different maker? Maybe it's some ingredients, or maybe it's the different brand. And then is there trouble getting the medications changed due to formularies? And the short answer is, again, yes and yes. Believe it or not, especially with the generic makers, which is most of the drugs we use, carbidopa, levodopa in particular, believe it or not, according to, I guess it's the FDA or whoever it is that regulates these things, I believe they really only have to be 80% similar or 80% identical or the same. But realistically, 20% is a big leeway either direction in terms of being too low or too high or not equivalent. Now, and classically, again, in our training, we hear this the most in epilepsy. So there are some epilepsy patients or seizure patients who are exquisitely sensitive to a certain brand maker or generic maker, and they really do need that one. If they switch because of the differences in how they're not exactly equivalent, then they break through seizures. It's less, I don't want to say it's less important in Parkinson's disease, but maybe it's a little bit less kind of life-threatening or maybe noticeable. But the short answer is yes, there are people who do prefer or respond better to one brand versus another, or they have a bad side effect or a tolerance problem to one generic maker versus another. That's not actually outside of the realm of possibility or even all that uncommon, actually. A lot of people notice when their pills change, meaning the pharmacy got a different generic maker, that they get different results with medications. The second part of that question is a little bit more difficult. So is there trouble getting the medications changed due to formularies? And the answer to that is sometimes there is. Generally, in my experience, pharmacies get whatever brand is cheapest. I mean, this is, again, a business, not surprising. And so if one generic maker of carbidopa, levodopa is going to sell to the pharmacy at so price, and another generic maker is going to be 10% less than that, you know which one they're going to go with. Sometimes the patients themselves can go to the pharmacist and say, hey, I see you changed the generic. This one doesn't work as well. Do you think I could go back and get the other one? And sometimes that works. Sometimes I can put on a prescription that says brand medically necessary. Usually we think about that in terms of actually getting the brand medicine versus a generic, but you can actually specify sometimes a specific generic like Mylan or something else. And sometimes that works. And sometimes the answer is no. They say, no, this is the best we can do and you're out of luck. I would say most of the time, I think when I've run into that as a problem, we've been able to get back on the generic, or we've just had to change something completely. So I don't think it's been as big of an issue, but that's kind of the answer to that question. Should be marking these as I talk about them. Body regulation. Are cold hands common with Parkinson's disease? Yes, again, as usual. So myself included, but a lot of my patients do end up having circulation problems, cold hands, cold feet, again, probably for two reasons. One is as you age, that tends to become more problematic or more noticeable. blood vessels don't work as well as you age. You get more arthritic changes as you age. So you do tend to get colder extremities as you age, but also in Parkinson's disease, your autonomic nervous system can be affected. So not only does the autonomic nervous system control heart rate and blood pressure and breathing and going to the bathroom, but it also controls temperature control, body temperature control, coming down to the hypothalamus or part of your brain. And so this part of your nervous system can be affected in Parkinson's disease. And so sometimes it doesn't work as well as it should. And that can also amplify or lead to kind of cold extremities. And so it's a fairly common symptom. Now, if you come to my office, you know, my hands are probably always colder than yours anyway. And so it can also happen just out of randomly, I guess. But I guess the short answer is yes, I do get that as a complaint a lot in my office. It's not something I'm really that good at fixing, except for you'll see I oftentimes have hand warmers in my white coat, so I can try to combat that. Wearing gloves, things like that's probably your best bet. The second part of that question is, if yes, does it happen more in patients with DBS or it makes no difference? I haven't necessarily seen a correlation with that with the deep brain stimulator. I think that's more a side effect or a part of the condition itself as opposed to the treatments. But I also never really asked about it, never really thought about it. So maybe I'll pay closer attention to it and see if there is any correlation. But as far as I know, I can't think that in my deep brain stimulator population that they tend to complain more about that or less. And so in my experience, I don't think it's really been correlated. If a form of dementia begins, does the patient stay with the movement disorder specialist for Parkinson's disease, or do they shift to different care, or does the patient and caregiver need a care duo? That's actually a really good question. You know, dementia or memory problems is not an uncommon symptom in Parkinson's disease. It's not everybody in Parkinson's disease, but it's not an uncommon symptom in Parkinson's disease. The short answer is it's whatever you're comfortable, whatever your doctor is comfortable with. Now, I don't want to say the good part of our training in movement disorders is, you know, and in terms of Parkinson's disease is a neurodegenerative condition. It's the second most common neurodegenerative condition, second to Alzheimer's disease, and Alzheimer's disease being kind of the main dementia or memory problem issue. And so in our training, sorry, I'm just signing back into my computer. In our training, we also get training in addition to Parkinson's disease and tremors and other neurodegenerative conditions, but in some memory problems as well. In fact, the mentor that trained me in her fellowship was actually a lot of dementia. Now, there are cognitive specialists or dementia specialists. In fact, we have two. We just hired another one. And so there are people or neurologists who are probably better at specifically dementia than I am. But it really comes down to what you're comfortable with. I'm fairly confident and comfortable in managing a lot of these memory problems, unless there's a specific thing, in which case I refer over to one of my partners. That may be true for your neurologist or your specialist. It may not be. But there's also nothing against having two people take care of you at the same time. I do that a lot with my headache patients. You know, I have patients with Parkinson's disease or tremors who also have migraines. And even though I can take care of migraines and I can take care of headaches, I do send them to the headache specialists that are my partners, not infrequently, and then we both take care of you. And so that's not outside the realm of possibility either. And if you're more comfortable with that, then that's fine. If you really want the absolute specialist, then you probably need both. But realistically, I think myself and a lot of movement disorder specialists are pretty well versed in the other neurodegenerative conditions like Alzheimer's disease, frontotemporal dementia, Lewy body dementia definitely comes to us more frequently, or even just generic memory problems or cognitive impairment. And so I think you would be okay with your movement disorder specialist, but that's really up to you. The last one on this page is about high frequency ultrasound ablation. Is there any new news about results since it became an option? Not that I've heard of recently. So high frequency ultrasound ablation is a technique that we can do to put a hole in your brain. Now you might say, why the heck do I want a hole in my brain? And the short answer is we learned a long time ago that if you put a hole in your brain in a certain area, we can stop tremors predominantly. It actually predates the deep brain stimulator by a bunch of years. That's how we found the deep brain stimulator realistically. And so at the end of the day, the high frequency ultrasound part is just the newest way and kind of the most sci-fi-ish or up-to-date technologically-ish way of putting a hole in your brain. And I often talk about high frequency ultrasound ablation when I'm talking about surgical options for tremors more than Parkinson's disease, but it's approved for both essential tremor and tremor predominant Parkinson's disease. The problem that I have with it for Parkinson's disease is that it generally works best for tremors. And again, you guys all know this better than I do. Tremor is not always the biggest problem, and it's almost never the only problem. And so I have never actually sent a Parkinson's disease patient for high frequency ultrasound ablation. I have sent several essential tremor patients for high frequency ultrasound ablation, and they have had good results. But realistically, because Parkinson's disease is such a multi-symptom disease, fixing just the tremor isn't necessarily as useful as I think it should be. And so that's why I don't send as many patients there for Parkinson's disease. Now, there is research ongoing. So one of the downsides to high frequency ultrasound is you can only do one side. And most of you guys probably know Parkinson's disease is a two-sided thing. They are researching whether or not you can get away with doing both sides. It also generally is aimed at tremor because of the target that they use, but they're also looking at other targets to see if we can work on other symptoms. But the short answer is no, I haven't heard anything new out of the high frequency ultrasound ablation realm yet. I did have a discussion with Dr. Murray, who is the doctor who runs the high frequency ultrasound ablation clinic down at West Virginia University. And she did say that they are working on these things, but I haven't heard anything recently. Which leads me to the next question. Have any Pittsburgh area patients traveled to receive it? So one of the things is it is not currently available in Pittsburgh. Neither us nor UPMC have the technology or the ability. And I keep asking for it, and they keep telling me no. And because it costs money, and as you know, healthcare is a big business, as I've mentioned before. And so at least not yet are they willing to buy it for me. And so I have had a handful of patients go down to West Virginia University where it is available and have the procedure done. Again, I haven't sent any Parkinson's disease patients. They've been all essential tremor patients. And the 3 or 4 that have gotten it have had really good results. But again, it still has some limitations, particularly in Parkinson's disease, in my opinion. And so I don't think we're quite there yet. Will it ever become available in our zip codes? Well, I sure hope so. I keep asking for one, and I keep getting told, no, they can't tell me no forever, is the short answer. And yes, I'm persistent. And so, again, at the end of the day, I do think eventually this is going to become mainstream enough or used enough or utilized enough or approved enough, because insurance coverage is also something that plays a role in everything that we do, or I guess money making enough probably is what is going to be the selling point to whoever's going to buy it for me, that eventually we will be able to get it. But I just don't think we're quite there yet. I don't think the people in charge are impressed enough by it yet. And so I think I still have a little bit of work to do before I convince them that maybe it's a good idea, but it's a work in progress. So at some point, I do think we'll have one, just not yet for a variety of reasons. All right, page 2. Is there an advantage or disadvantage to taking more carbidopa levodopa if eating protein is unavoidable within the hour of taking the medicine? So let me backtrack a little bit on this question. So what they're getting at on this question, which some of you may have known or a lot of you may have noticed, is that food, and in particularly protein and in particularly large amino acids, impact the absorption of levodopa. And so, and the reason for that is the transporter that absorbs levodopa from your intestine is the same transporter that is used for large amino acids. And so if you only have so much transporter, it can only pick between one or the other, and some of your levodopa may not be being absorbed. That's a simplified version, but that's the best way to understand this. Now, if you have a huge amount of this transporter and you have so much extra that it doesn't matter how much protein you eat, you can still absorb all the levodopa, then obviously you're not going to notice any problem. If you don't, because of genetics, you only have a small amount of this transporter, then some of that transporter is going to uptake protein and it's not going to absorb all of your levodopa, and you're going to notice a significant impact in whether or not your medicine works or how well it works. And again, this is why some people notice it and some people don't. The short answer is you could try just flooding your system with more levodopa, But again, at the end of the day, if you only have so much transporter, that might not work, because you could have as much levodopa floating around in your stomach and small intestines as you want. If you don't have enough transporter to pick it up, it's not going to get absorbed. And so the short answer to that question is sometimes that strategy works and sometimes it does not. Okay. And so that's a little bit of a tough question. A better solution is, again, either avoiding protein when you're taking your pills, meaning taking it on an empty stomach, which does tend to work a little bit better, or maybe trying a different medicine or some sort of different strategy or some sort of different scheduling to see if that would work. Again, not to say you couldn't try that, but again, I'm not entirely sure how effective that would be. Is there a drawback to taking carbidopa levodopa when the symptoms reappear, i.e. off time, rather than waiting to take the medication at a specific time, as long as the dosage isn't excessive? What about taking a half of the dose sooner? Well, now we're talking about strategies as to how you avoid these motor fluctuations. And so what you're getting at is, how do we smooth out the ups and downs? So motor fluctuations are a big issue in a lot of patients. Again, particularly the higher the dose that you're on, the longer that you deal with the condition, the less effective your medications become. So maybe initially they cover you the entire time, but then you start noticing it's shorter and shorter, and then you start having this wearing off, this kicking in, i.e. these motor fluctuations that people develop. Is there a drawback to it? I mean, maybe. Again, at the end of the day, we don't like to just ramp up the dose, although that is one strategy. And oftentimes I will say, well, let's move your pills closer together and let's add in another more frequent dose, or try taking a half a pill in between as a rescue medicine, or some of the other rescue medicines like the inhaled levodopa and Bresia, or the thin film, the Kinmobi, or even the old Apokyn that was an injection. Those are all strategies to try to avoid these ups and downs. But at the end of the day, there are other things you can do. So you could use a Nupro patch. You could use a longer lasting levodopa like Rytari or controlled release Cinemet. Or you can just take more frequent dosage. You get what you're getting at with this question is, how do you get around motor fluctuations? And there's a lot of different strategies you can try to see if you can make that happen. In my patients, I'm not against necessarily taking moving your pills closer together, or even taking half when you feel like it's wearing off and then half at the normal time. All of those are reasonable strategies. And what you're going to find, or what, excuse me, I always tell my patients, is it's trial and error. It's trial and error. Excuse me. Give me 1 second. I'm going to put you on mute here. I'm back. Sorry about that. I'm also on call, and so unfortunately, we have a really sick patient on the floor, and that was about that. So, apologies to everybody. And so I believe we were talking about kind of motor fluctuations off, on, off, and at the end of the day, it's best to just have this discussion with your neurologist, with your movement disorder specialist. They can figure out what's the best plan for you to really see if we can work on that. The last question that I have on the paper here is, what does the direction of a fall, forward, backwards, sideways, indicate? And you probably noticed that every time, well, at least early on, especially the first time I see somebody, I'll ask them about falling, and specifically, what direction do you fall? And the reason why I asked what direction do people fall comes down to really distinguishing between Parkinson's disease and some of the Parkinson's-like conditions. So predominantly progressive supranuclear palsy, which is a Parkinson's plus condition. Generally, Parkinson's disease patients tend to fall forward. And so they tend to get going a little bit too quickly. Maybe their upper half keeps going and their feet freeze or stick and they can't keep up, or they break into a run or something called festination. And then they fall down. And so usually Parkinson's disease patients will fall forward, or maybe to the side. And only later in the course do they tend to fall backwards or retropulse, things like that. Whereas progressive supranuclear palsy patients or PSP patients tend to fall backwards. They have a lot of axial rigidity, meaning their trunk is stiff, their neck is stiff, and a lot of times they just describe it as, it feels like somebody just pushes me over backwards. And so when you see somebody who you think or you're suspecting one of these Parkinson's-like conditions, and they say, especially early in the course, this is the first time I've seen them, they've had it for a few months or a year, and they fall backwards all the time, that at least registers in the back of my mind. I'm thinking, okay, is this an atypical Parkinson's-like condition, like a PSP or something else? And at the end of the day, again, it doesn't necessarily change our plan or change what we do, but it does change kind of my expectation for what's going on. And so that's what I'm looking for when I'm asking, okay, what direction do you fall? Do you fall forward? Do you fall backwards? Again, that's not absolute by any means. I have a lot of Parkinson's disease patients that fall backwards, but that's what I'm usually looking for when I'm asking those types of questions. The one last question that I got on email here was actually about DBS, and this is something specific, which I normally wouldn't answer, but I don't know the answer anyway, so I'm going to bring it up. Somebody got a new generator, an active RC, and it says not to expose it to metal, which I'm not entirely sure about, and therefore the question was, can I still recharge it with a staple still in? I would think you could, but I'm honestly not sure of that. I would call neurosurgery, whoever did the implant or whoever put it in, and see what they say. All right, I think that was the last one I had here. I'm going to go see what's in the question and answer section as soon as I get this out of my way. There we go. All right, moving on. All right, I have a lot of stomach discomfort. I can't determine if it's medication related or Parkinson's, which is more likely, and is there a solution? Which is more likely? Honestly, I would have said it's like 50-50, really. A lot of patients with Parkinson's disease, and I'm not telling you guys anything you don't already know, end up with a lot of GI problems. So the entire gastrointestinal system slows down or stops, top to bottom. So swallowing, esophageal motility, gastric emptying, intestinal motility, colonic motility, constipation, i.e., it all is affected. And yes, the medications also tend to lead to a lot of upset stomach. In fact, that's the number one side effect. And so I would say it's probably 50-50 in terms of which is more common. And there's not a great way to determine what's causing what outside of stopping the medications, which is not always a great plan. So that's not what I'm telling you to do. The only thing I can say is, does it seem to correlate with when you take your doses? And maybe it's not as bad when it wears off. But even then, a lot of patients are not all that great at determining, or it's not always that obvious. And realistically, it probably doesn't matter. Is there a solution? No. Are there treatments? Yes. So again, in my world, I don't fix anything. I don't have a solution for anything. I never solve anything. I never fix anything. I never cure anything. Do I have something we can do? Probably. I have something we can do for just about everything. Usually it's a workaround, it's a management, it's something like that. And so this first step is take your pills with food. Yes, they're less effective, as I just said 35 seconds ago, but it does tend to help calm down an upset stomach from medications. The other alternative is try switching your medicines. The other alternative is I do refer a lot of my patients to a gastroenterologist in cases like this to see if there's something else that can be going on or something else that needs to be looked at. Do they need to do a scope, or do we need a medication? Can we try something like Zofran or one of the anti-nausea medicines to see if it would help? Do they have anything for motility? And I'll tell you, they don't really have good things for motility, but maybe there's something they can think of. Is it coming from slow, bowels and constipation? It's just backing all the way up. Do we need to work on that? I mean, the short answer is yes, there's always something we can try or we can do. But the more you're able to pinpoint it, or the more you're able to pay attention to it, or more you're able to figure out about correlations with medicines, time of day, going to the bathroom, eating, anything you can sort of correlate with it would help us try to figure out what's the best first choice to see if we can make it better. And then it comes back to, just like everything comes back to, which is trial and error, and we see what we can accomplish. Are all of the following considered Parkinson's disease? Thanks. No problems. Perfect. You're the best. So nice to have good help. Let me tell you, there is nothing like having somebody who is really helpful. And in my case, my entire team is very helpful, but my nurse practitioner is extremely helpful. There is nothing better than having good teammates. Anyway, are all the following considered Parkinson's disease? Tremor, dystonia, and bradykinesia. How does the medical field classify the different types of Parkinson's disease? If you don't have tremor or dystonia, do you only have classic Parkinson's disease? And do you eventually get all three? There's a lot of questions in there. I'm going to try to break it down one by one. So the main symptoms of Parkinson's disease, or Parkinsonism, which are the symptoms of Parkinson's disease, are tremor, which is a resting tremor, rigidity, which is usually cogwheel rigidity, which is different than dystonia, but I'll come to that in a minute. Bradykinesia, which means slowness of movement, and in fact, that is the most important symptom for you, and postural instability or balance problems. Those are the four cardinal features of Parkinson's disease. Those are the symptoms that get you the diagnosis. They at least get you the diagnosis of Parkinsonism. I generally call it Parkinson's disease when you have those symptoms that are typical, that respond well to medicines, that present in a usual fashion, and all the usual stuff. Those are really the four symptoms that you need to get a diagnosis. You don't need all of them. You only need a couple of them. You need bradykinesia, so you need to be slow, and then you need one of the other main ones. You don't ever have to have all of those symptoms to get a diagnosis of Parkinson's disease. You don't ever have to have a tremor to get a diagnosis of Parkinson's disease. As long as you're slow and then you have stiffness or walking and balance problems, you can get a diagnosis of Parkinson's disease without the other ones. We traditionally, or I don't want to say traditionally, in research, we have tried to break it down into different subtypes of Parkinson's disease. So you'll hear tremor predominant Parkinson's disease. You'll hear akinetic rigid type of Parkinson's disease. You'll hear these different terms, or you'll read these different terms in terms of trying to classify Parkinson's disease or break it down, thinking that that would help us either come to an underlying realization of what causes it, or be better able at fixing it, or come up with a cure for this type, but it really hasn't panned out, is the short answer. We really haven't noticed that one type is necessarily genetically or inherently different or responds to a different set of medicines or anything like that. And so, again, you don't need all the symptoms, the classic symptoms to get a diagnosis, and really differentiating between the subtypes really hasn't been as helpful as we thought it was going to be. There was a lot of hope in research or in trials to try to make that differentiation, thinking it was going to help, and it really didn't. Dystonia, on the other hand, is a little bit different. So dystonia is not the same thing as rigidity. Cogwheel rigidity is what I'm feeling for in the office. When I take your wrist and I move it up and down, or I extend and bend your elbow, I'm feeling for rigidity. And so it kind of catches. It goes catch, 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 a lot like a socket wrench or a ratchet. Dystonia is a little bit different. So dystonia is abnormal muscle contracting leading to fixed and twisting postures. And so dystonia is a part or a symptom of Parkinson's disease, but it can also be a standalone thing. And so instead of thinking of dystonia as that rigidity, dystonia is more like the toe curling that some people get, or the fisting posture that some people get. So it's more like extreme stiffness that actually leads to posturing of different muscles or joints. In cervical dystonia, they come in with a head turn and they can't straighten up their head. So that's different than the rigidity, which is a cardinal feature of Parkinson's disease. At the end of the day, we generally treat them all similarly, especially when they're related to Parkinson's disease, but we do try to differentiate primary symptoms from secondary symptoms from motor and non-motor symptoms, and really determine what's the best treatment strategy for them. But the short answer is to get a diagnosis, you don't really need all of those things. There isn't really a lot of benefit differentiating one versus another, or a subtype versus another. All of our medicines are purely symptomatic management anyway. And so I don't spend a whole lot of time subtyping people or patients or anything like that. Hopefully I answered all those questions. Is there some, so kind of coming back to the same thing, is there some kind of matrix that shows all the symptoms of Parkinson's disease to classify what type of Parkinson's you have? Is the medical field classifying types? If you had a matrix to show all the symptoms of Parkinson's disease, I mean, it would take up more than just what I have drawn on my whiteboard here. It would be huge, because if you've listened to this long enough, you know that just about any symptom you could think of can be a symptom of Parkinson's disease. And no, I wouldn't say that we've done in the medical field that we've really utilized the grouping system or the classifying typing system, because it really hasn't panned out for us. There is a general thought that maybe the akinetic rigid patients, i.e. the people that have a lot of stiffness and not as much tremor, don't do as well as the tremor predominant Parkinson's disease. But I don't think that always pans out either. And so I don't necessarily use that as a guiding tool. And I don't know that anybody else does either, but again, that is my own practice. And so again, I don't think that information is necessarily as useful as we had hoped or we were hoping to use for our practices. It's something we still pay attention to, but I don't think any more than that. About the cold hands. Does it tend to happen more at any particular stage? I would say it tends to happen as the disease progresses. Again, maybe that's just when I notice it or when people complain about it. And again, that's also with aging. And so maybe those two all tie together. But I would suggest that I hear about it more kind of as the disease progresses. I don't know that it's necessarily kind of loss of dopamine cells directly relates or leads to cold hands, but maybe there is something to that I'm not sure. But that's what I would say on that. Is there anything new to help treat hallucinations? Depends how you define new. The short answer is no. The longer answer is Nuplazid is probably the newest way to treat hallucinations. It's the only FDA approved medication for hallucinations secondary to Parkinson's disease or Parkinsonism. There are older medicines that we've used, such as Seroquel, which we still use a lot of. And then there's Clozaril, which nobody ever uses because it requires an insane amount of blood work and monitoring to get. But realistically, those are the choices that we have outside of decreasing medications, which we think drive hallucinations. Is it a work in progress? Yeah, I mean, the hallucinations are still a big issue for a lot of people. And what we have is not perfect. It's not even great by any means. It's okay. It's acceptable. It does help a lot of people, but it's not everybody. And I have plenty of patients that have not responded to the medications, and it's still a big issue. And so it is still a very big unmet need. I can't think of anything that I've heard of recently in the grapevine or at any of the meetings in terms of new things that are being tested or looked at. And so the short answer is the disappointing no. We're still left with kind of Clozaril and Seroquel, which are the old versions, and then Nuplazid, which is the newest medicine, and we kind of go from there. I heard that they're going to make 25 100 Cinemet pills scored in fourths instead of just halves. Why don't they just make quarter pill size that we can take without cut? That's a great idea. If I had to guess, the answer to that question comes down to money, because the answer to every question ultimately comes down to money, in my opinion. You might call me pessimistic. I like to call myself realistic, but we're splitting hairs here. My guess is pills are probably made in certain sizes, or however, I've never actually seen how a pill is compounded and made, in all honesty. I don't know what machinery it takes to do such a thing, or how many they can produce and what type of time frame. But that sounds like a great idea to me. If they can make different sized pills that didn't require cutting, that's a tremendous idea. Put that in the suggestion box somewhere. I don't know where the suggestion box is, but if you find it, put it in. Because I do have a lot of patients that break them in half or even break them in quarters. And it's not just Cinemet where they do this, it's just about every medicine known to man. And even though, carbidopa, levodopa does come in other sizes, like a 10/100 or 25/250, they're not equivalent, and the controlled release is not equivalent to the immediate release. It's about, 3/4 or 2/3 of the dose. And so there's not a great conversion. And so, yeah, I think your idea is a fantastic idea. And so if we could find a way to make that happen, that would certainly make a lot of patients happy, or their lives a little bit better. I don't know if they'll do that. I don't know what it would take to actually do that, or how they would measure that out, or what kind of machinery they would need to produce those kind of things, but it sounds like a great idea in my book. I find that if I just take into a quarter of a pill, it's like a rescue dose, and sure it is. And that's not uncommon. In fact, that's what we did for a long time before they started inventing rescue medicines. And I still have people do that. I absolutely, especially early in the course, when, if I have somebody on 3 pills a day or 4 pills a day, and maybe they have some bad days and some good days, and we don't want to increase their medicine across the board, I'll say take an extra half when you need it, or take an extra pill when you need it, or, a quarter. That's not an unreasonable way to try to solve that problem, and especially to try to solve that problem without increasing medicines across the board. Now, obviously, if you end up taking a quarter of a pill or a half a pill every day, then you just need more medicine. But again, when you're on the edge between doses, that's not an unreasonable thing, in my opinion. I don't know if everybody does that, but it seems very reasonable to me. And believe me, if you can find a manufacturer, if you can convince somebody that they should make quarter-sized pills, I will absolutely back you up and support you. I'm going to give you a hint. They don't care what I think either, but it maybe, it never hurts. Never hurts. All right. My dad has started to take the full dose of his medication. His tremor hasn't decreased. Should we have seen some improvement by now? Yes and no. I mean, at the end of the day, when I start somebody on medication, I love it when they improve right away. I feel the best when they get better right away. Obviously, they feel the best when they get better right away. Everybody's happy. Everybody believes that I know what I'm talking about when what I expect to happen happens, and there's a lot of trust there. And when that doesn't happen, it's tough. It's not uncommon though, believe it or not. When I put people on medication, they don't always get better right away for a lot of reasons. In fact, for a reason that I'll tell you in a second, sometimes tremor gets worse, and then they really get mad at me. And so at the end of the day, not everybody responds to medicine the same way. And so the short answer is yes, I would love it if you noticed a difference or it got better. And yes, I was hoping if it was me, I was hoping that you would get better, as your doctor I'm sure was. But just because you didn't get better with the first amount doesn't mean we're done. It's not uncommon in my world for me to put people on medications. They send me a message a month later and they say nothing different, and then we just adjust. We either ramp up the dose as long as you're tolerating it. We could add in something else. We could switch to something else. There are other choices depending on what we're trying to accomplish. Tremor, on the other hand, is sometimes one of the harder symptoms to fix. In fact, carbidopa levodopa itself works better on stiffness than it does on tremors. It works well on tremors in a lot of people, but at the end of the day, there are some people that it doesn't seem to work as well for. I have some patients where they take levodopa and everything else seems to get better except the tremor. Sometimes tremor really is a tricky symptom to try to get better. And like I said, sometimes when I put people on medication, they actually shake a little bit more. And then they call me up and they say, hey, that didn't work. I'm shaking more. And then I take the medicine away and they feel worse. And the reason for that is again, you can imagine if you're shaking, but you're stiff, it's going to be lower than if you're shaking and you're not stiff, right? So it's called undampening a tremor. If I give a patient a medicine and it fixes or it treats their stiffness more than it treats their tremor, the tremor could actually become higher in amplitude. So it actually could appear bigger. And really what that means is all I've done is treated your stiffness more than I've treated your tremor. And we still do the same thing. We try a little bit more medicine, we adjust things and we see what we can do. But that's actually not an uncommon situation when I put somebody on a medicine who I think has Parkinson's disease, and then they call me up and they say, hey, that actually made my tremor worse. And when I see them, it's because they're less stiff. Again, not ideal because tremor often bothers people the most out of the movements, the motor symptoms, because other people notice it, they notice it, so on and so forth. And so what I would say is it sounds like there's just more work to be done. Again, if you haven't responded to a certain dose, either you need more of it, we need another medicine on top of it, we need a different medicine. We need to think of something else that we can do to see if we can get you doing better. And the choices are out there. You just have to figure out what's the best choice for you. But the short answer is yes, not everybody gets better when I put them on medicine, especially from a tremor standpoint. And in fact, sometimes they do get worse. So I have any thoughts about immunotherapy to treat Parkinson's disease? Not necessarily. And here's why. There really has not been an immunotherapy that's worked. So probably the most recent one was the adalimumab, the leukemia drug that everybody got really excited about down at Hopkins, because nobody actually bothered to read the paper that they published and suggested that it wasn't a great idea. But anyway, when it did get studied, it didn't work. And I've seen other things tried. I've seen other neurologists, for better or for worse, try other types of immunotherapy for tremors, for Parkinson's disease. I've seen IVIG used. I've seen plasma exchange used, believe it or not, although I'm not sure how they got it covered, but I've seen it tried and I've never seen it work. Similarly, even something, talking about immunotherapy, something as simple as steroids, which we use first line for a whole lot of neuromuscular conditions or nervous system conditions, and they generally help. I've never seen actually work for patients with Parkinson's disease. I don't know that they've been studied, but in my experience, I've never seen it work. And so my impression of immunotherapy of any kind really has been, I haven't really seen it work in any way, shape, or form for Parkinson's disease. And so, again, I'm not against considering it. I'd be interested if there's papers that are coming out or if there's studies that are looking at these things that do show promising results. But I just haven't seen any to this point. Hopefully I hit what you were talking about. The Cinemet pill that will be scored into fourth is oblong instead of round and will not fit into a standard pill cutter made for, well, that stinks. Something you might not have known is I believe pharmacists can sometimes cut pills for you. I don't know if that's true for all pharmacists everywhere or for everything, but I've had patients where their pharmacist will cut some of the pills, especially if they're scheduled to take half pills. So that might be something, because I've also never tried to cut a pill, although a lot of my patients have. And so it sounds kind of iffy if they're putting a pill that doesn't fit into a pill cutter and they want you to cut it. I mean, that doesn't sound like a great solution at all. But a lot of people, I don't think, know that sometimes pharmacists will cut some of the pills for you if you ask them to, or if you need them to. You can at least try. I have had some patients who got their pills cut by their pharmacist because they were unable to do so. Again, I don't know if that's, maybe some people just are friends with their pharmacist, or some pharmacists are nicer than other pharmacists, just like some doctors are nicer than other doctors. Not sure which end of the spectrum I fall on. But I have had some people get that done. So that might, if you are somebody who has to take 1.5 pills or quarter pills or things like that, that might be a reasonable thing to ask your pharmacist for. But coming back to your comments, again, that sounds silly to me. I mean, I guess you can just try cutting them if they do score them, but I mean, that sounds like it half defeats the purpose if it doesn't fit into a pill cutter. So if you just have dystonia, you don't have Parkinson's. Yes. Yes, I think. I'm thinking about that. Yeah, I'm making sure I'm not just making stuff up, because I do make stuff up, as I mentioned. But no, I think that is an accurate statement. Dystonia is not technically a good diagnosis. Dystonia is a description of a movement. And so I explain this to medical students and residents all the time, but I often forget to explain it to patients a lot. Tremor is not a diagnosis. It's a description of a movement. Chorea, hemibolismus, dyskinesia, dystonia. These are not really diagnoses. These are descriptions of movements. So as a movement disorder specialist, I spend 99% of my day watching, observing. My whole job is to observe and comment. So I have to pay attention to everything. And most of what I do is describe movements. Dystonia is a description of a movement. Dystonia as a definition means abnormal muscle contractions leading to fixed and twisting postures. That is the definition of dystonia. And yes, you can absolutely have dystonia and not have Parkinson's disease. Cervical dystonia is actually the third most common movement disorder. And it has absolutely nothing to do with Parkinson's disease. It is a completely different diagnosis, a completely different treatment strategy, a completely different thing. The problem with dystonia as a word is it does not tell you anything about the underlying cause. And here's where people get into trouble with dystonia. Dystonia can be a standalone disease, i.e. Generalized dystonia, cervical dystonia, focal dystonia. It can be part of another disease, i.e. Parkinson's disease. So again, a lot of my Parkinson's disease patients do get toe curling or cramping or fisting. That's a dystonic posture in the setting of Parkinson's disease. Dystonia can be a genetic thing. So there's a whole variety of DYT genes, which are dystonia genes that usually manifest in children as wheelchair-bound, severely disabled kids. It can also be a sporadic thing. So the majority of cervical dystonia is not a genetic thing. It's a sporadic thing. It's the most common adult form of dystonia. Writer's cramp is a focal form of dystonia. It's not usually a genetic thing. And so the word dystonia is, again, not a great diagnosis because it doesn't tell you anything about what you're seeing. It's just a description of the movement that you're seeing. And so if I see somebody who comes in with a head turn, I will label them or say you have cervical dystonia, suggesting that it's a neck problem and head turn. If I see somebody who has toe curling in relationship to Parkinson's disease, I will just say you have dystonic posturing of your feet or your toes secondary to Parkinson's disease. And so usually you have to classify or qualify the dystonia that you're talking about to really relay the information that you're trying to relay. Because if I just say dystonia to another doctor, that's not really going to tell them much about what I'm seeing, what the problem is, where the problem is, or what we're going to do about it. And so the short answer is you can have dystonia in addition to, you can actually have dystonia and Parkinson's disease. You can have dystonia as a symptom or a part of Parkinson's disease. And there are many, many patients that have just dystonia and do not have Parkinson's disease. And so I don't know if I explained that necessarily as clearly as I would have liked to, but hopefully I relayed the information to you that dystonia and Parkinson's disease are indeed different. Can dystonia be caused by dehydration and lack of electrolytes? Sure, just like cramping can be. And in that case, or is the dystonia related to Parkinson's caused by low dopamine? Again, sometimes. So I'm always wishy-washy in my answers, as you guys have figured out by now. In my world, there's not a lot of definitive answers and there's not a lot of definitive fixes. Welcome to my world. You can get dystonic spasms due to dehydration and electrolyte problems, just like you can get cramping. A lot of my patients get knots in their calves and Charlie horses in their legs due to dehydration. Dystonia can be the same thing. You can get that toe curling or that dystonic posturing, your foot turning in, or your upper extremity. It doesn't just have to be a lower extremity, secondary to dehydration. Is the dystonia related to Parkinson's caused by low dopamine? Sometimes. So, and this is where paying attention to the timing of your symptoms or the patterns are really, really important in terms of figuring out what's causing it and what do you do about it. So if you find that your dystonic spasms are every time your pills wear off, then yeah, it's a low dopamine problem, and increasing your medicine might help with the dystonic spasms. If you find, and there are some patients that, much like you can get a dyskinesia, that when your pills overshoot, you get dystonic spasms. In that case, it wouldn't be caused by low dopamine. It would be caused more by overshooting of the dopamine, much like a dyskinesia, but that can also present as a dystonia. And sometimes it doesn't actually matter. There's no correlation to the dopamine levels, and we just have to figure out what to do. And so I would say the most common type that I see is usually an off dystonia, where pills wear off, foot cramps, toes curl, foot turns in, and it's painful. I would say that's probably the most common one that I see, but that's not always necessary or the case. When you observe a patient, what visual things I'm looking at everything. What visual things am I looking for? Believe it or not, the examination starts as soon as I walk in the room. As soon as if I go out and get the patient, which sometimes I do because I'm a very impatient person and I can't wait for the medical assistants to go get my patients. And so sometimes I just say, I'll go do it myself. The exam starts when I see it through the window or through the doorway. The exam starts, or my observation starts, as soon as I lay eyes on the patient. And I am looking for everything you can think of. I am looking at how do they look in general? Do they look sick? Do they not look sick? So believe it or not, probably the one thing that you learn in medical school the best is determining who is sick and who is not sick just by looking at them. How are they sitting? How are they standing? Are they leaning? Where's their head position? Is it drooped? Is it up? How's their facial expression looking? Do they look upset? Are they relaxed? Are they anxious? You can tell this all by looking at people. And then I start looking for all the other things. So how are they sitting? Are they shaking? Is it one side versus another? Everybody does rapid alternating movements, finger to nose testing. How's the coordinated movements go? How's the walking look? What's your posture like? Are you flexed forward? Are you leaning to one side? Do you take short shuffling steps, or your feet wide apart? Do you use a cane? Do you use a walker? How do you turn? Do you take short shuffling steps when you turn, or do you pivot? Do you not pick up a foot? Believe it or not, that I honestly don't even think I could list all of the things that I look for when I'm watching a patient. But I am looking for every symptom or every sign, I guess it would be, that I can pick up just by looking at things. And you can actually learn and pick up a whole lot of things just by watching. It's amazing. I can almost diagnose people just by watching them. When you see enough patients and you get an understanding or an idea of what they do, how they look, what it usually means, observation is the most powerful tool that I have. And it really does work pretty well. And then you superimpose on that what you guys tell me. And between history and physical examination, you come up with almost every bit of information you need to know. Especially in my world where there's not a lot of testing, there's not a lot of MRI findings or blood work findings or EEG or EMG or spinal tap. My world is predominantly dominated by physical exam or observation and history taking, meaning talking to patients. And so I'm observing a whole lot of things when I'm looking at you, and I'm watching you. Even when you don't think I'm looking at you, I'm looking at you. And I usually can pick up everything I need to know. How long do most people diagnosed with Parkinson's disease go before they start medication? I don't know. I'd say it's variable. So first of all, a lot of people go a long time before they even get diagnosed. So usually when I see somebody, I say, okay, when did you get diagnosed? Because people don't usually come to me for a diagnosis. They usually get a diagnosis for somebody else, but sometimes I give the diagnosis. And if I'm the one giving the diagnosis, or when they tell me they get diagnosed, I say, okay, when did your symptoms start? And it's almost invariably a year, 2 years, 5 years before they got diagnosed. And then after diagnosis, again, it's variable. The decision for medication is individual. And it always comes down to how much are the symptoms impacting your day-to-day life. And that does not just depend on how bad the symptoms are. That depends on how bad the symptoms are, but also what you're doing in a day-to-day life. Are you working? Are you relaxing all day? Are you going in public? Are you staying at home? Are you doing manual labor? Are you sitting in an office or a desk all day? What you're doing is also almost as important as how bad your symptoms are, because it really comes down to how much are the symptoms impacting your quality of life, impacting your day-to-day life, bothering you or disabling you. That's really how you make the decision. And so you can imagine that's variable. That is completely individualized. I have plenty of patients that as soon as I make the diagnosis, we put them on medicine. And part of that is because they've had symptoms for a while and they've progressed. And I have just as many patients where I diagnose them and we say, let's wait, let's focus on exercise. Let's get you to the gym. Let's get you up. Let's get you moving. Let's see how you do. Let's give it more time. Your symptoms are there, but they're not keeping you from doing things. You don't need medication. Again, the medicines aren't disease modifying. They're just symptomatic treatments. And probably everything in between. And so that's a hard question to answer. I would say I have equal number of patients that go on medicine right away as don't, and the ones that don't, sometimes they go a year, 2 years, 3 years, and they still do great. And I never put them on medicine. And sometimes they call me in 6 months and say, hey, it's time, let's put you on medicine. And so that's a little bit hard of a question to answer. It's a little bit variable. And so, it really is individualized in terms of that answer. And I know I took a break on you, so I'm going to go a little bit over as long as nobody kicks me out, and because I can. Is exercise the only thing to slow Parkinson's disease? Is it actually preventing the dopamine generating neurons from dying? I don't know the answer to either of those questions, actually. Exercise has been shown to delay the onset of Parkinson's disease, or it has been shown. What it's been shown to do is that people that exercise are less likely to go on to develop Parkinson's disease than people who don't. That's what's been shown. I and a lot of other movement disorder specialists have extrapolated that to it being disease modifying, meaning that if you are going to get Parkinson's disease, or if you have Parkinson's disease, it delays the progression or slows down the disease. That has not definitively been shown, but there are a lot of studies out there that suggest that. And so my personal opinion is that exercise slows down disease progression. Now, does it do it because it prevents dopamine cells from dying, or does it do it because it helps mitochondrial function or blood flow? Or does it purely do it because a fitter person with better muscle mass and muscle control does better than somebody who doesn't have that? I don't know the answer to that question. Nobody knows the answer to that question. It might do all of the above. It might do a combination of things. But the short answer is exercise, in my opinion, is the only thing to slow down Parkinson's disease or keep you better longer or alter the disease course. I am not entirely sure how it does that. I sort of care how it does that because I'd love to mimic it with medication. But at the end of the day, I don't care how it does that. It just does that. And this is exactly why, if you listen to enough of these things, I spend a lot of time talking about exercise. If you're my patient, I spend a lot of time talking about exercise, because I really am a believer that exercise slows down disease progression and keeps you better longer. Is that definitively shown? No, not necessarily, not according to a lot of specialists out there. But at the end of the day, I personally do think that it does slow down disease progression, and I highly recommend it to everybody. I'm going to finish with one question that it was either last time or the time before that I said I was going to get to, but then I didn't. I feel like it was last time because I had technical difficulties last time. And the question was, am I optimistic that there's a cure in the near future? And if you guys were on last time or the time, I think it was last time, but my memory doesn't always work well either. Then I told you I was going to answer that question. I was going to give you my opinion, and then I didn't. And that was not very nice of me. Nobody questioned me. Nobody said, hey, you forgot to tell us that. But I remembered after the fact that I didn't answer the question because I had it written right in front of me and I never came back to it. So I'm going to come back to it now. I do think there is a potential cure for Parkinson's disease, but I don't think we're anywhere near it. And here's why. I know that sounds disappointing, and believe me, I am just as disappointed as anybody else in this game. And here's why. Because I don't think we're ready for a cure yet. I personally think that there are a couple of steps that need to be accomplished before we come to the final step, which is here is a medicine that is disease modifying or slows down the disease or cures. And the steps that I think are missing are, number one, a biomarker, meaning right now there is no marker of Parkinson's disease. There's no marker of disease progression or that correlates with disease progression. There's nothing measurable for Parkinson's disease. And then what that leads to is a test, either a genetic test, a marker test, a diagnostic test. Again, as I told you, the diagnosis is based on those 4 symptoms. The problem is that anything that gives you those 4 symptoms gets classified as Parkinson's disease or Parkinsonism. And so the way that I describe that to my residents, in fact, I just had this conversation with them earlier today when I was teaching them something, is that if you take everybody who has Parkinson's disease, because they have those cardinal motor symptoms, let's say there's 100 different things that leads to those symptoms, which is probably not unreasonable. Anything that leads to those symptoms gets diagnosed with Parkinson's disease. And so even though it's 100 different things, it's all called Parkinson's disease. And so let's say I come up with a cure, or I come up with a disease modifying therapy or a medication that fixes a certain type of Parkinson's disease. How is that going to be trialed? Well, it's going to be trialed in Parkinson's disease. But as I mentioned, that trial is going to have everybody who gets diagnosed with Parkinson's disease, which is all 100 of the underlying causes of Parkinson's disease. And invariably, even if I fix 1 or 2 of them, it's still going to be a negative test because I'm not going to fix the other underlying causes of Parkinson's disease. And therefore, it's never going to show what it actually does, which is that it fixes a small subset or a small cause of Parkinson's disease. And so without a marker, without a test, without a way to differentiate, and genetics is doing this to some extent. You know, there are LRRK2 genes, there are PARK1, PARK2, SCA, glucocerebrosidase or GBA. There are genetic versions of Parkinson's disease where we're doing this somewhat, but realistically, to extrapolate to the masses, we really need markers of the subtypes of Parkinson's disease. Because until we can start breaking down into the subtypes, and again, I'm not talking about the symptom subtypes, I'm talking about the underlying cause subtypes, then we're going to have a hard time coming up with a medicine that cures or slows it down. And so I do think that's possible. I just think at the end of the day, we're not there yet. And so I think there are steps that we need to get to before we get to the cure part. And so while I am optimistic that eventually we will be talking about cures and disease modifying medications, I don't think we're there yet. And I think we have a couple of steps that we have to get to before we get there. And with that, I'm going to stop. I think I answered all the questions, at least as many as I saw. And at the end of the day, I went way over time anyway, even though nobody's popped up and yelled at me. I'm sure everybody's thinking in their head, stop talking. And so again, as long as you guys keep sending me questions, I'll keep answering them. The next one is sometime next month. I have no idea when. Casey probably knows when. But keep sending in the questions and we'll keep doing it. Casey, anything from you?
Just that the recording will be available on our YouTube channel. A few people have asked.
I didn't even know there was a YouTube channel.
Yes,
so great.
just go to our
the YouTube
website.
channel.
Go to our website, pfwpa.org, and then you'll see the YouTube icon in the top right corner. You can see all of the wonderful programs. Thank you, everyone. Have a nice holiday.
Perfect. Thanks, guys. Have a good one. See you next month.